The broadcast is now starting. All attendees are in listen-only mode.
Welcome to the VDEC webinar series again. This webinar is going to be taken by myself. I'm Dr. David Clark, a diplomat of the American Veterinary Dental College and also a registered specialist in veterinary dentistry. I have a practice here in Melbourne, and tonight's webinar is going to be on radiology. So many of you in practice will be taking radiographs as part of your general veterinary work, including radiographs of the legs, chest, etc. There's not a lot of difference between taking a radiograph of the mouth and teeth, but there are some smaller points that we probably will discuss as the seminar continues. So radiology is a vital tool in veterinary dentistry, and we can use it in many different areas. In particular, we can use it to assist in the diagnosis of disease, which is probably going to be about 75 to 80% of the work in a normal practice, to diagnose diseases such as periodontal disease, for example, loss of the structures surrounding the teeth. We can also use it for treatment planning as well. If we're thinking about extracting a tooth, we might consider also taking a tooth out, for example. We also would consider for monitoring oral disease. So in this particular case, we might consider taking a radiograph if we've done, say, pulp capping or something along that line, and we could measure whether the treatment has been successful. For example, we could look at the width of the periodontal ligament, for example. So I think what we'll do is we'll slowly go through each of these sections. We'll also have a look at and diagnose some of the situations where we might take a radiograph. We'll also have a look at diagnostics of radiography as well, and we'll also look at how to take a radiograph, and also some of the techniques in separating roots of, say, upper fourth premolar teeth. So some of the reasons that I alluded to with diagnostics could be checking for abnormalities. The most common would be things like missing teeth, misplaced teeth, acquired disease such as bone and tooth structures. We can also look at things such as trauma and also neoplasia. We also look at the possibilities of treatment. So commonly we might take a radiograph for, say, tooth resorptions in cats, determining whether we want to take the tooth out or whether we should do crown amputation and pulp capping. We could also look at endodontically compromised teeth. These are teeth that may be fractured, for example, and whether we're going to do pulp capping or whether we're going to be able to do a root canal, for example. We can also look at diseases such as periodontal disease as well, and I will show you some cases on periodontal disease. And also preoperative radiographs can be useful. Things like root structures. There are many roots that might be twisted or curved, or when the tooth is difficult to extract, you might take a radiograph to make sure that the root is okay. If a tooth is missing and you haven't extracted it in your clinic, it'd be worthwhile taking a radiograph to see if the tooth is ankylosed, for example, or whether there's an infection around it. We also will take post-operative films to gauge treatment success, especially when we're doing extractions as well. In our practice, we also see a large number of puppies, and a lot of them are show dogs, and what we'll do is we'll take full mouth radiographs on the puppies at around 10 weeks of age to see if the permanent tooth buds are present, because a large number of breeders like to sell the dogs and guarantee, well, I suppose you can't really guarantee, but you can ensure that there's actually 42 teeth in the dog's mouth, and you can actually say to the client that's actually buying the dog, they actually have all the teeth. So that's always good to know as well. So we can discuss that as also. So what do we need to take a radiograph? Well, you do this in practice every day, so you know pretty much that you need a X-ray generator, which we call a radiograph machine. We also need something to actually collect the X-rays and turn them into something we can read. So this would be either a film, like a traditional cassette film, which is available as an intraoral film for dentistry, or there's now sensors available, which are related to computers, so the DR sensors. And then you need a processor in order to develop the image. So a typical processor, as you're aware, that could use developer and fixer, or you can use a computer as your processor. So initially, let's have a look at the X-ray developers. You're well aware of the X-ray generators, which are on the left-hand side. We can see the typical veterinary atom scope, which you're all well aware of. The difference between this and the dental tube head, which we can see on the right-hand side, is that the veterinary machine is quite flexible in the amount and the degree of kV, MA, and time, which can all be interchangeable. And that's mainly because we have different size animals, we have different size legs, chests, and different sorts of tissue that we're trying to get the X-ray to actually penetrate. So a large dog, for example, would use a much higher kV than a small dog, for example, which you're well aware of. Now, this differs from a dental tube head, which is the picture you can see in the middle of the slide there. And the difference mainly is that with a dental tube head or a dental X-ray generator, we set the kV and we set the MA. So for the best radiographs, we'd normally set the kV at 70 and we'd set the MA at 8. And what's changeable for a dental radiograph is the time. So on a lot of the newer X-ray generators, they actually have algorithms within the machine. So you'd need to choose the animal and the tooth if you're going to take a particular area of the mouth. So for example, on the right-hand side here, you can see that there's a circle on the panel which represents the open mouth view. On the top of that circle are the incisor teeth, and then going down the side of each circle, on the left-hand side, you can see the light is lit up on the canine tooth. Then it goes to the premolars and then the molars, and then down the bottom of the circle are the mandibular teeth. So the difference essentially is that you choose the tooth and you choose the animal, and then the algorithm within the machine pretty much sets the time for you. So in many ways, it's much easier to determine what settings to choose on an X-ray generator for the mouth compared to the rest of the body. I'd encourage you to purchase a dental X-ray tube head as one of the first things you purchase when you start taking X-rays and doing more advanced dentistry, because you'll find that it's much easier to take a X-ray, take a radiograph of the mouth if you have a dental tube head versus a veterinary one, mainly because of the positioning factors of a dental tube head, because the tube rotates around 3 axes, and you'll find that in practice it saves you a lot of time. This is an example of the dental generator, which you can purchase. There's many on the market. The one on the left-hand side is available as a mobile stand, perfect if you've got multiple tables or multiple rooms. And the one on the right-hand side attaches to a wall. So ideal for the practice that is limited in floor space, or if you're working from 1 or 2 tables, and you can obviously utilize it in that fashion. So an X-ray generator is something definitely worth purchasing. The next item which we should consider is the type of film or sensors that are available. So traditionally, radiographs have been taken on film, film in cassettes in the veterinary field, and film which we call intraoral film in the dental field. So the picture of the film on the left-hand side is encased in a black, the film is the green resin in the middle. It's then encased in a black piece of paper, which is then inserted into a plastic envelope. And it also has a piece of lead foil on the back to prevent scatter. The film is coated in a gelatin layer, and that inside the film is all of the silver crystals, which is like a typical veterinary film, and the silver crystals is what turns the radiograph black, so you then get the contrast, the black, the white, and the various shades of grey on your radiograph. These films are available in multiple sizes. The picture that we're showing there is what's called a size 2 film. A size 2 film is traditionally 24 by 40, sorry, 31 by 41 millimeters in size. It's about the size of a large postage stamp. It's very flexible, which has its advantages and disadvantages. The flexibility allows you to put it into the mouth and avoid the tongue and the other hard structures, but the disadvantage is with a flexible film, you do sometimes get elongation and shortening of the actual image, so that's a downside. They're very inexpensive. They're generally a size 2 film will normally set you back around 50 cents, 50 Australian or US or New Zealand cents. A larger film, say a size 4 film, which is about 4 times the size 2 film, which is normally about 57 by 76 millimeters in size, will normally set you back about $3. The disadvantage of these films is that you use them once and then you have to store them, similar to the veterinary cassette films. The next film, which is what we call a phosphor-plate film, which is utilized by the CR computer system, is a resin plate as well, and it's also covered by phosphate crystals. It's available in multiple sizes and it's flexible. It has a minimal cost. Most of these are around the $200 to $300 mark, and they have a shorter lifespan than the digital sensors on the right-hand side, but one advantage is you can use it multiple times. So you can normally get hundreds of uses out of one of the phosphor plates. Now, the disadvantage, I guess, is if it gets bitten by an animal, then the plate is wrecked, and the more radiographs you take on them, the quality decreases slightly as well. One of the other disadvantages that you have to take the film from the animal's mouth and actually put it into a processor in order to get your radiograph. The latest technology is on the right-hand side, which is the digital sensor. It uses the Cosmos and the scintillator technology. A scintillator essentially is a material that when it's excited by the X-rays, it absorbs the X-rays energy and scintillates. In other words, it produces energy in the form of light, and then that is transferred via or into the computer, which then via the software produces the radiograph. The DR or the digital sensors are available in 2 sizes, normally sizes 1 and 2, and a representation of those would be in the middle where you're looking at the phosphor plate. So you can see the size 1 and the size 2 phosphor plates there. The advantages, I guess, I think one of the advantages of the digital system is that it's not flexible. In other words, you don't get elongation or shortening of your actual image. Some would say that's a disadvantage because you can't bend the plate around the tongue and around the other soft tissues or hard tissues. It is much more expensive than the phosphor plates or the intraoral films. Generally, the DR systems vary between about $7,000 and $12,000 for the plate, and also for the software that goes with it. It has a much longer lifespan than either of the other 2 systems. You can get up to 10,000 images on the digital sensor. Another big advantage of it is it's very fast compared to the phosphor plate. The phosphor plate requires you to physically take the plate out of the dog or the cat's mouth, walk across to the processor, wait for it to be processed. So you can be looking anywhere from 10 to 30 seconds to get your image. And the advantage of the digital sensor is that a lot of them are very fast, so you normally have your image within 2 to 3 seconds. So for a beginner or a novice who is taking radiographs for the first time, one of the advantages therefore of the digital sensor is that it stays in place in the mouth, so therefore if the image isn't perfect, you just need to move the tube head or the sensor slightly and it's very fast, so you can take multiple radiographs until you get the right one. Versus if you were to have a phosphor plate, you've actually taken it out of the dog's mouth, and therefore the chances of you putting the plate back into the same position is quite high. So therefore you could end up with the same radiograph again. So let's have a look at let's say we're starting on a low budget and we want to use intraoral film. So intraoral film is processed in a similar way to veterinary film. So we use a developer and we use a fixer. We would use those in small cups, and we would need a darkroom. So many veterinary clinics now have gone away from having a darkroom, and because they're using DR and CR technology. So the way to get around that would be to set up what's called a chairside developer. Essentially, it's called a chairside developer because it's used chairside by the dentist, because if you think it, when you're at the dentist, you're actually laying down on the chair. So this is a box which is light protected from the outside, and it has 4 cups on the inner part of the box, and it has a light sensitive top, so that in this particular case it's orange. You can also get red depending on which type of film you're using. So you can see on the left-hand side there's a cup that has developer in it, and then the cup across to the right-hand side has water, and then the next cup has fixer, the next one has water, and then you can see there's little film clips as well. So on the front of this box are 2 black areas. We'll just go back a step. You can see there's 2 black areas on the front of this box. They're for placing your hands into the box. So you're actually doing all your work inside the box, and then the lid goes down. So you can see here, my assistant has her hands through the holes in the front of the box, upper left-hand picture here, and they're peeling back the film, peeling back the black plastic and the paper within um, the cartridge in order to get the film out. So then on the next picture on the upper right hand side, you can see that the film is being exposed, and then on the lower left hand side the film is being placed onto a clip. The clip then allows you to place it into the cups. So initially you place the film into the water cup for 15 seconds in order to hydrate the gelatin and emulsify it so that the actual film is available for the chemicals in the developer. And then the film is placed in the left-hand side and developed. So if we go to this one, you then put the film into the developer for 30 seconds. You then give it a wash in the water just to wash off any of the developer. You then place it in the fixer for 60 seconds, so it's actually fixed. And then you can actually have a look at the film, so you're actually able to take it out of the box and actually have a look at it. If the film has a good radiograph on it and it shows you everything you need, then you can keep it by placing it back into the fixer for another 5 minutes, and then it's permanently fixed, and then you can put it back into the water for a final rinse. So that's an inexpensive way of starting off with dental radiology, by purchasing intraoral film and by getting a manual chairside processor and using rapid developer and fixer. So when you start taking a large number of radiographs, so I guess my definition of a large number would be 3 or 4 patients on a day, and you might be taking 4 or 5 radiographs on each of those patients. So you might be taking, say, 20 radiographs. What you'll find is that the time really sets you back and really slows you down, and you'll want a faster way of developing your films. And also, if you're taking that many pictures, in theory you should be able to afford a more expensive machine. So the CR system on the left hand side and the DR system on the right hand side are a faster way of producing an image and producing your radiograph. So the CR systems will cost you similar amounts to the DR systems. They normally range from around $7,000 up to about $12,000. And their main advantage is the quality of the radiograph and also the speed which you're able to take it. So now you're able to take the radiograph. What we'll do is we'll have a look at some of the normal radiographs, some of the normal findings that we'd see on a radiograph, and then we'll have a look at some of the um, pathologies that you'd also expect to see as well. So this is a radiograph of a normal mandible. We can see that the first molar tooth is in the middle of the picture, and that's the one we're mainly looking at. The top of the tooth, which is signified by the arrow, is the crown of the tooth. We can see that this area here is the crown of the tooth as well. So this is a double rooted tooth. So on the left-hand side, we've got the mesial root, and then on the right-hand side, we have the distal root. So it's a double rooted tooth. In the center of the roots, between the roots in this area here, we can see the furcation, and we can see that the bone extends all the way into the area where the roots divide, up adjacent to the crown as well. So that's the first item that I look for to see whether the bone around the tooth is healthy. You can also notice that the bone around the apex or the periapical area of the roots here, see by the lowest arrow on the mesial root, is quite continuous and consistent, and there's no voids in the bone as well. So that's a healthy picture of a bone. The next item to look for is the width and the nature of the pulp canal. So the radiolucent area running down the middle of the root is called the pulp canal. It's a black or a radiolucent line. The pulp canal is wide in a young animal, and we'll see that in a radiograph in a minute when we look at deciduous teeth, and it's narrower in an older animal because the dentine is laid down. We then look at the radiolucency around the root, and we can see that there's a periodontal ligament. The black radiolucent line that's running around the root here is the periodontal ligament, and that's healthy as well. So the main factors with a healthy tooth is that you have healthy bone around each root. You don't have any lucencies in the periapical area, so you have a consistent ligament around each tip of the root. You have a regular, healthy black radiolucent line running down the middle of the tooth root, which is the pulp canal. It can be assumed, and it's also found in every dog and cat, that there's only one pulp canal per root, so you don't have to be worried about having two pulp canals like in people where you might have 2 or 3 pulp canals per root, and that the periodontal ligament is healthy around the root as well. So they're the normal radiographic findings that we would expect to see in an animal. So if we look at disease, let's look at the first one, and we'll look at periodontal disease to start with. And this is a clinical picture where we have a typical animal with periodontal disease. You can see up in the upper left-hand corner, there's plaque and calculus, there's gingival recession. We'd find that there's deeper periodontal probing depths on this particular pet, and we also have probably mobile teeth as well. So we're taking a radiograph of the maxillary teeth by placing the tube head laterally at about a 45-degree angle, and we'll talk about tooth and x-ray positions later after we've looked at some clinical examples. But the tube head is placed, if the dog's head is placed axially and the dog is in sternal recumbency and symmetrical, then the tube head is placed at around 45 degrees to both the horizontal and the vertical to get a normal radiograph without elongation and shortening. So in this radiograph, we can see that the dog has advanced periodontal disease. We have loss of the alveolar bone. This is you can see the alveolar bone height is here around the first premolar. There's significant loss of alveolar bone around the tooth to the point where really only the apex is what's holding the tooth actually in the mouth. The second premolar, being a multiple rooted tooth, also has lost alveolar bone around the mesial root, but is also, because of being a multi-rooted tooth and has a furcation, also has lost a large amount of the alveolar bone within the furcation as well, which is seen as a radiolucency between the roots. And then the third premolar in this radiograph is showing us what a normal and healthy tooth should appear like. And we can see that there's healthy bone within the furcation. There's a normal periodontal ligament around the tooth as well. And for all intents and purposes, that's a healthy tooth. So we've got alveolar bone loss, loss of periodontal ligament and cementum, and we'd have deeper periodontal probing depths around the canine and the first and the second premolars in this particular case. Another example of and where we would take radiographs would be in cats where we have tooth resorptions. So we can see at the top on the clinical picture, there's gingival hyperplasia, edema and hyperemia around both of the premolars, the mandibular premolars and also the molar tooth there. And that's a consistent clinical picture of a cat with a tooth resorption where you get loss of the enamel, loss of cementum and also dentine as well. And then in the two radiographs, we type tooth resorptions into 1 and 2. And in type 1, what we see is a loss of the actual tooth structure consistent with both dentine and cementum disappearing. And you can see this in the right-hand radiograph. On the molar tooth, where the arrow is pointing, we have a normal mesial root with a normal periodontal ligament around the root, but the distal root is completely resorbed. Now, one of the reasons why we would consider taking radiographs for this particular condition is to help us with treatment choices. So in this case, we would expect to use a normal extraction using normal elevators to break down the periodontal ligament and take out the tooth entirely. This is different from a type 2 lesion where you get a mottling and a thinning of the dentine and the cementum and actual ankylosis of the tooth and replacement resorption. So the tooth is actually being replaced by bone. So what you find is, you can see in the picture on the left-hand side where the arrows are pointing, there's a loss of the periodontal ligament and you're getting ankylosis of the tooth onto the bone. So it'd be very difficult, except to extract that tooth en bloc, it would be very difficult to take that tooth out. So a treatment choice there would be a better choice, would be crown amputation and then covering the exposed bone and tooth with gingiva. So you can see how taking a radiograph would help you with your treatment choices in this particular case. So the next example we could take radiographs would be persistent deciduous teeth. We can see here that the dog is presented, it's a young puppy generally. It has persistent upper or maxillary canine tooth on the right-hand side in this clinical presentation on the left. If we were to put the dog in sternal recumbency and its head on the towel so it's slightly elevated, we would take a radiograph with the tube head angled at around 45 degrees to the horizontal and the vertical, with the dog's nose slightly elevated. When you take your radiograph, you can see here in the middle radiograph that you've got both the persistent deciduous maxillary canine and also the permanent maxillary canine. The permanent tooth is on the right-hand side of the radiograph and the deciduous tooth is on the left-hand side of the radiograph. And the purpose of taking a radiograph in this clinical situation would be to determine whether you have the entire deciduous tooth or a partly resorbed deciduous tooth. So when you actually extract it and only half of the tooth is removed, because of the radiograph you can determine whether you need to go back and actually remove the other half of the tooth which may be left behind. So if the tooth is half resorbed and you're taking it out and you've only removed the resorbed part, then on the radiograph you can determine that there was no more tooth there. We often see in dogs a missing tooth. In show dogs, this is very important because they can't be shown if they're actually missing teeth. So my advice would be to radiograph missing teeth when you see them. This is very important for show dogs like German Shepherds and Dobermans, for example, that need all 42 teeth to be shown. So when you take the radiograph, you can tell the owner that the tooth is either missing or it's retained. And if it is retained, then you may be able to do a perculectomy where you cut the gingiva and allow the tooth to grow through the gingiva. So in this case, this particular dog was missing a first premolar tooth. You can see on the clinical example on the left-hand side that there's a canine tooth on the left. There's an absent, or there's a space that suggests an absent or missing first premolar, and then there's a second premolar. So this is these are radiographs on the right-hand side where you can see on the top radiograph there is no first premolar. And there's no indication that it was actually there. And on the bottom radiograph, you can see that there's a first premolar. So taking radiographs of missing teeth can help you determine whether they're there or not. It can also determine if the tooth has been fractured and the roots are still under the gingiva, even though you can't see them or feel them, which would indicate that you might want to go in and actually remove the roots to avoid future infection or inflammation as well. Another good example and a perfect position where you would actually take a radiograph is when you have a difficult extraction. So if you take a radiograph before the extraction, you can see whether you have a curved root, a root that's partially resorbed and therefore may be difficult to extract. So this is a cat that presented after a car accident and had multiple fractured teeth, fractured canines, and also some periodontal disease of the premolars as well. But you can see the X-ray positioning is with the head and the cat in dorsal recumbency, the head as possibly parallel to the table, and you can see the X-ray plate is parallel to the table, and the tube head is angled at about 20 degrees from the vertical, and that gives you a good position for the lower canines and the lower incisors. You'd want to angle it slightly laterally if you want to get the premolars in as well. So with the radiographs, you can see on the left-hand side, you have a canine tooth that has a bit of resorption on the middle of the root there. There's also some loss of the alveolar bone in the middle. In this position here, you can see that the bone is slightly flared outwards. On the premolar, you've got a furcation exposure and you've got a reasonable amount of resorption of the tooth roots as well. So it's highly likely that the tooth may fracture at the cemento-enamel junction and therefore leave the roots behind. So the teeth are extracted. And then radiograph on the right-hand side shows that they've been removed completely. So at least then you know that you're not going to have any problems in the future from infected roots or retained roots. You can then remove a small amount of the bone to smooth it off and then suture the gingiva over the top. So a good reason to take radiographs would be in extraction cases. For more advanced dentistry, you can also take radiographs for, say, root canals or endodontic work. It's a good idea to take multiple radiographs when you're doing root canals because you want to check the working length of the files. So this is a cat that presented after an accident and it had 3 broken canine teeth. Root canals were performed on all of them, the 2 mandibular teeth and 1 of the maxillary teeth as well. And that's the picture on the left-hand side. Then moving down, so moving across to the right-hand side, immediately downwards is a radiograph of the teeth to ensure that the teeth aren't, there's no root fractures or there's no damage to the surrounding bone, which there isn't. The radiograph in the middle shows an endodontic file in the tooth, and that's to ensure that the file travels all the way down to the apex, which is called the working length, because when you're doing a root canal procedure, you need to ensure that the entire pulp is removed. The teeth are then cleaned out or reamed out using the file, and then flushed, and then they're obturated with a gutta-perca material. So the next radiograph, the third one across, one on the right, shows that the root canal is completely obturated with sealer and gutta-perca, which is that white radio-opaque material inside the tooth. And then the last clinical picture on the top right is the teeth when they've been restored. So we can see that radiographs are very useful, and it would be almost impossible to do good advanced dentistry such as root canals without radiographs. Here's a radiograph of a fractured fourth premolar looking at periapical lucencies. So periapical lucency is the area around the tooth root, which you can see here signified and by the top arrow, and you can see there's a radiolucency around the root there. It looks a bit like a wine glass. It's often said it's a wine glass appearance. The periapical lucency indicates that you have possibly, well, you definitely have inflammation around the tooth root. It's highly likely that you've got an abscess or osteomyelitis, although histologically is the only way you could tell whether you had a cyst or a granuloma. But I believe in 99% of the cases in veterinary dentistry, an abscess or a periapical abscess and osteomyelitis is the most common reason why you would be presented with this particular radiograph. You can also see and visualize in this particular radiograph that you've lost the periodontal ligament around the tip of the root as well. So the actual loss of bone and the osteomyelitis has actually resorbed away the periodontal ligament and also any of the alveolar bone around that particular tooth. So in this case, it's caused by a fracture. So the dog has chewed on a bone, most likely. We can see by the clinical presentation on the left-hand side that the tooth is fractured. It's lost that mesial cusp, thus exposing the root canal to oral bacteria. Bacteria then travel down into the pulp chamber and into the actual root canal, and then travel out through the apex and into the surrounding bone. And you can see from the clinical picture on the upper left-hand side the positioning of the tube head at about 45 degrees, and in this particular dog we're taking it from the rostral aspect, and I'll show you how to separate the roots soon, but we're taking it from the rostral aspect, and what that does is it separates the mesial and the palatal roots, as you can see by the radiograph, but it also positions the distal root over the molar, so you get superimposed distal root over the molar tooth, which is often hard to find out if you've got any pathology there. So there's some clinical examples of how and why you would take radiographs and what you would expect after you've actually taken the radiograph. The actual technique in taking a radiograph can be either really, really simple and easy or quite difficult. Now, the simple and easy techniques is called the parallel technique, and we often use that for mandibular teeth, and we'll talk about that in a minute. The more difficult technique is called a bisecting angle, and that's where you have to use a three-dimensional picture to avoid elongation and shortening of the actual tooth roots. And I'll talk about that in a minute as to why we use a bisecting angle. But the aim and the reason why we're thinking about the techniques is that we're trying to get a correct image on the actual film so that we don't have elongation or we don't have shortening of the roots of the teeth, very important for root canal procedures. Also, if you've got periodontal disease or you're trying to extract a tooth, you want to know how long the root is and how much bone is around the tooth as well. So the first way to take a radiograph would be what's called the parallel technique, which you perform each day when you take a standard veterinary film. This has the sensor or the film parallel to the actual image that you're taking, which in this case is the tooth. So the film and the tooth are parallel, in other words, adjacent to one another, and the tube head is aimed at 90 degrees or perpendicular to the tooth and the film. So you end up with a pretty much correct size tooth immediately on the film. Now, the problem with this in veterinary dentistry is that we can only really put the sensor or the film parallel to the tooth between the tongue and the mandible. So from about the second premolar to the last molar tooth in the dog, and both premolars and molar in the cat, this is the only position where you can really take up and use a parallel technique. For all of the other teeth, because we have a flat hard palate, unlike our own hard palate, which is more like a vault, we need to use what's called the bisecting angle technique. So we take a three-dimensional view of the tooth, the film, and where the beam is going to travel. And what we do is we place the film as parallel to the tooth as we possibly can, as we can see by the picture on the lower and also the diagram up top here. And we then take the angle of the tooth. So we look at a line that travels down the axis of the tooth. So we now have two lines. We have one which is traveling down the line of the tooth and another one which is traveling along the length of the film. And we draw an imaginary line between those two, which has an angle between the imaginary line in the tooth line and the imaginary line in the film line being equal. So that this line here bisects, and that's where the technique comes from, it bisects the angle between the tooth and the film equally. We then position the tube head at 90 degrees to this imaginary line. So this is how we would take a canine tooth. If we were to do that in color, then you can see that the film is along this red line. So the axis of the film, or the way the film has been placed in the mouth, is along the red line. The angle or the axis of the tooth is along the green line. So from the tip of the tooth to the tip of the root is along the green line. The blue line here then bisects both the green and the red equally, and then the tube head is angled at 90 degrees to the blue line, which is the yellow line. So it's not as difficult to interpret and take with a little bit of practice. What you need to do is you need to get some film, and ideally I would practice on a skull initially, where you can actually see where all the teeth are, so you don't have all the soft tissues in place. And then once you get the positioning correct, then you can just use your vision to determine how you're going to take that picture and take that film. Similar technique with the premolars. The only difference is that the teeth, if the dog is or the cat is in sternal recumbency, then the teeth are pretty much vertical, and you can try and put your film as horizontal as possible, which then produces a bisecting angle at 45 degrees to those two. And then the tube head is essentially aimed at a perpendicular angle to the bisecting angle, so the tube head is angled at about 45 degrees to both the horizontal and the vertical line as well. If you were to take that technique and aim the tube head directly at the upper fourth premolar, because you've got two mesial roots, what you'll find is that the roots will actually superimpose themselves over each other, and you won't actually be able to see anything. The other concept too is that if you were to move the tube head in order to reposition the roots so you actually have them separated, you need to be able to determine which root is the mesial root and which root is the palatal root. So we determine that by using what's called the Slob rule or Clark's rule, which essentially says that when the tube head is moved, what will happen is that the lingual or the palatal root will move in the same direction as the actual tube head. So here are two examples. The first one is taking a radiograph of the upper fourth premolar tooth with the tube head positioned in a rostral fashion. So in other words, the tube head is moved towards the dog's nose. So using that rule, one would assume that if the tube head is moving rostral or towards the dog's nose, then the lingual, or in our case, the palatal root, would also move in the same direction. So therefore, if you look at the radiograph, you've got the mesial roots on the right-hand side of the film, and you've got the distal root. And well, I've taken a radiograph of a root canaled tooth, so you can see the obturated roots. So there's 3 obturated roots in this radiograph, so you can easily see which root is which. So the red arrow is pointing at the distal root. That will always stay distal. But you can see that you've got a yellow and a blue arrow. So the yellow arrow is pointing at the buccal root, and the blue arrow is pointing at the palatal root. So if we move the tube head towards the dog's nose, in other words, towards the mesial or the rostral aspect, so on this radiograph, we're actually moving it to the right-hand side because the mesial roots are on the right-hand side, then the palatal root will move in the same direction as the tube head. So you're moving the tube head from the middle of your computer screen across to the right-hand side, so towards the nose of the dog. And what you're then finding is that the palatal root moves with you. And the opposite occurs with the buccal root. So the buccal root moves away from the dog's nose. A similar situation occurs when you move the tube head towards the dog's tail. So in other words, if you move the tube head in a caudal fashion, you would also expect the slob rule to apply. So the lingual root, or the palatal root in our case, is going to move in the same direction as the tube head. So you're moving the tube head towards the caudal direction or the tail of the dog, and therefore the palatal root is also going to move towards the tail of the dog. And you can see in this picture, where the dog is positioned on the left-hand side, the tube head is moved towards the tail. And you can see in the radiograph that the palatal root now, the blue root, is also moved in a distal or a caudal direction as well. So you can see that the palatal root is now closer to the distal root, so it's moved in a caudal direction, whereas the opposite root, which is the buccal root, is moved towards the nose or towards the rostral aspect as well. I think one of my plans will be to actually maybe to take some videos of actual taking radiographs and positioning the tube head and then putting them up on the website. So on our website, VDEC, which is the Veterinary Dental Education Centre.com.au, what I'll do is I'll take some video of actual positioning and then some still pictures as well to put it all together for you. So I'll try and do that in the next few weeks to make it a bit easier to understand. But if you think of slob as in same lingual, opposite buccal, that's the way the actual roots move. So one of the difficult things that I've found in taking radiographs, I guess, is trying to remove the zygomatic arch from the fourth premolars in cats. And most of our radiographs, and what we encourage veterinarians to do, is to take intraoral techniques. So in other words, putting the actual film or putting the sensor inside the animal's mouth. By definition, an intraoral technique. And this really works for probably 90% of the teeth, and all teeth in dogs and 90% of the teeth in cats. The one that's really difficult to take using an intraoral technique is the upper fourth premolar. So on the left-hand side, I've used a skull just so you can see where the tube head is and where the film is, or in this case a sensor, and where the teeth are, so we don't have all the soft tissue and the tongue in the way. But what I'd encourage you to experiment with, I guess, initially is to try an extraoral technique rather than an intraoral technique. So on the left-hand side, now what have I done here? Ignore these pictures and I'll change them over later, because what I've done, sorry, and I apologize, is I've actually put the pictures, like the clinical picture, in the wrong position. So just ignore the picture and listen, and I'll tell you. So we've got the intraoral technique, which is the picture on the right-hand side, the clinical picture on the right-hand side, but it's associated with the radiograph on the left-hand side. So you can see that using the picture on the right-hand side, this picture here, what we've got is the intraoral film inside the cat's mouth, and we end up with a radiograph with the zygomatic arch covering the upper fourth premolar. So it's very difficult to see the roots here. Now, if you were to use an extraoral technique where you actually put the sensor on the outside of the animal's mouth, as you can see by the clinical picture on the left-hand side, what you can see is that the film or the radiograph that you end up with, which is the one on the right-hand side, the zygomatic arch isn't covering the roots of the upper fourth premolar, and you can actually clearly see the individual roots. So it's much easier to visualize the mesial and the distal roots using an extraoral technique rather than an intraoral technique. And what I'll do is I'll change those over at the end of the presentation and put them back up for you. I apologize for that. So in summary, I believe that we should be taking more radiographs than we currently do, because we should be able to use them to diagnose disease. We should be able to use them to aid in our treatment plans and also make our life easier for situations such as extractions. We can also use them for advanced dentistry, such as root canals. There's been quite a number of papers that have been published, especially in the Journal of Veterinary Dentistry by Frank Verstradi and his previous resident, Melinda Lommer, and they showed in one paper that at least 67% of pathology is located subgingivally in cats. So if you don't take radiographs, you're actually missing a lot of the subgingival pathology. They also published another paper which showed that about 1 in 10 or 1 in 11 cats have subgingival tooth resorptions that you don't actually pick up unless you take a radiograph either. So for cats, I personally recommend that you take full mouth radiographs in every cat prior to doing the procedure, and we do that in the clinic, and we get a stack of pathologies that we would never see otherwise. Depending on who you talk to, some veterinary dentists recommend taking full mouth radiographs in dogs. I don't believe that we get I guess enough pathology to justify the time and the amount of radiographs or the x-rays you produce, because you also need to think of, you know, the dogs being exposed to the x-ray, your staff being exposed to the x-rays. So we now in our clinic, and I recommend that we take radiographs in breeds that are prone to disease. So brachycephalics, for example, you could take radiographs. You could justify taking full mouth radiographs. Chihuahuas, like the smaller breed dogs, you could justify that. Whenever you see pathology, you also would be able to justify taking radiographs as well whenever you see pathology, either on an oral exam or on probing. So thank you very much for attending. If you have any questions, feel free to post them up. We'll post the presentation online soon, and I will continue like the recording, and I'll go and change the pictures. So if you continue to listen, you'll obviously get the pictures in the correct position in a minute as well. So I'll just go and do this now while we're chatting. And thank you very much for attending. Okay, so for everyone who is either still watching or anyone who is listening because they haven't been able to attend, we now have the maxillary fourth premolar showing the separation of the zygomatic arch and the upper fourth premolar. So on the left-hand side, we've got the intraoral technique, and you can see that the film, or the sensor in this case, is intraorally, so it's inside the mouth, and the tube head is positioned rostrally. And in that particular situation, we often will end up with a zygomatic arch, which is covering the upper fourth premolar tooth roots. And you can see it's very difficult to visualize the mesial roots. So I recommend, and I now take an extraoral view for the upper fourth premolar in cats, and you can see that the sensor is positioned on the right hand side now. The sensor is positioned on the outside of the mouth, and the tube head is angled probably at about 80 degrees, 75 to 80 degrees, with the cat in lateral recumbency, and we end up with a tooth, and you can see the upper fourth premolar here. That dark radio opaque area just on the mesial side of the upper fourth premolar is calculus. We can then see the entire crown, and we can also see all of the roots. So thank you for attending, and we'll post this up on the website. Now we have a question. So the first question is from Helen. How many radiographs do you need to do a full mouth in cats, and how do I charge for them? We take 6 to 7 radiographs in order to get a full mouth in a cat. We'll take the mandible, we'll get both canines and all incisors on one film, and we'll get both premolars and a molar on another film, so left and right, so there's 3. We'll then take both the extraorals and get, as you can see here, 2 or 3 premolars and a molar on the left and right, so that's another 2, so now up to 5. And in a small cat, you may be able to get the 6 maxillary incisors plus the 2 canines on one film, but in a larger cat, if you're using size 2 films, you may need to take 2. So between 6 and 7 films generally, and I find our nurses can normally do a full mouth series in about 2 minutes using a DR system. We charge, if we're taking a single radiograph for a diagnostic purpose, we charge $60.50. If we're taking a full mouth, I think we charge $187 for a cat and $287 for a dog. So significantly less than if you were to take 6 or 7 times $60, because we're trying to encourage everyone to, obviously accept that we're doing that. So hopefully that answers your question. Another question from Helen. How far so you recommend that the tube is placed from the head? Oh, that's a really good question. The advantage of using the dental X-ray generator is that you have the actual collimator, which is that clear cone that you can see there, and the film focal distance between the anode and the end of the cone is set. So to answer your question, you just place the end of the cone right up against the skin, and that actually answers that that question. So essentially the end of the collimator is right up against the skin. Any other questions? No. Oh, that was, oh, thank you. Excellent. Okay, well, thank you very much for attending. As we said, we'll post this up on the website, which is vdec.com.au. My plan is to do another webinar in a month's time, so the second Tuesday of the month. So the second Tuesday in December will be the next one, and we'll be covering alternatives to extraction. So other things you can do rather than extracting the tooth. So we'll cover periodontal disease and fractured teeth, luxated teeth, and other possibilities of trying to save the tooth rather than having it extracted. Okay, thanks very much, and I'll talk to you soon.